Apologies, everybody listening, for my poor connection. Tamsin is currently a professor in Cambridge. She's a well-recognized international epidemiologist. She had done her training and her PhD in the Institute of Psychiatry before moving to an academic post in Exeter and then going to Cambridge just last. Looking to have back up the research priority. Thank you.
Thank you, Fiona, and thank you to everybody for your attention and your interest. I'm delighted to be here today, and I'm going to talk a bit about the research priorities in terms of the mental health impacts on children, but I think that's also tied up with how we can best protect children. So I will do a fairly formal presentation. Please pop questions in the chat. It would be really helpful if you could keep your microphones muted, because otherwise we can get sort of horrible feedback happening. And then I hope to be able to have a discussion with you at the end via the questions in the chat. So without further ado, oh, there we go. We need to start with the mental health context, certainly in the British Isles at the time when COVID hit. So I'm sure you're all aware that there had been hints in the Good Childhood Survey, other kind of convenience sample surveys seem to be reporting a deterioration amongst children's mental health, but we hadn't had a population-based survey for a long time. So to try and get at the question about really were we having a crisis in children's mental health, colleagues at University College London led this analysis of repeated surveys of different people. These were very large surveys, often dealing with a multitude of issues, very superficially with questionnaires, and some of them had mental health measures, either reported by parents on their children or by young people themselves. And we had data from England, we had some surveys from Scotland, and then to a lesser extent from Wales. And these were collected on these different samples over a 20-year period. And what was very interesting is there wasn't consistent evidence of a trend of deterioration on the scores of the validated measures. And these related to children as young as 4 and young people into their mid-20s. But where there was a consistent year-on-year trend across all 3 countries sampled was the willingness of parents and young people to say, yeah, I think I have a mental health problem, or I think my child has a mental health problem. Now, this is not necessarily a bad thing, because if we have more people willing to say, I have a mental health problem, and we can get them into effective treatments, of which we have many, then actually that is a good thing. I think, I hope some of you at least are aware of the Department of Health in England's big survey. So we've had a series of surveys over the last 20 years. The first was in 1999, the second in 2004, and they should have been repeated every year, every 5 years. But 5 years on from 2004 was 2009, and I think, to be honest, the government didn't want the answer, let alone to pay for it. Anyway, with a lot of lobbying, because the adult survey did go ahead in 2007 and it did go ahead in 2014. With a lot of lobbying, we had a survey that was completed in 2017. And that suggested that amongst the school-age population, going up to sort of the end of 6th form, 1 in 8 children had a clinically impairing mental health disorder. Now that's based on a multi-informant standardized diagnostic assessment. So parents of children under the age of 16 were interviewed. Young people from the age of 11 up were interviewed. And if the family agreed, a briefer version was mailed, excuse me, mailed to their teacher, and then a small team of clinical raters put information together from all three service sources to think, if I saw this child in the clinic, would I think they needed treatment? So that was the question we were being asked to answer for government. I should say that 1 in 20, so that's 5%, met the criteria for 2 or more disorders, and they were more impaired. So mental health problems are common. This survey was unusual for 2 reasons. It extended the age range down to preschoolers for the first time. And in fact, there have been remarkably few studies of very young children like this, of population-based samples across the world. So this is one of a handful of studies. And therefore, the government want to treat this data as experimental. I don't think it is experimental, actually, but I think that's partly because people were very shocked by the finding that 1 in 18 of children under the age of 5 met diagnostic criteria for a mental health condition. It was certainly what the press picked up on when we first released the results. But the million-dollar question that I started with was, is children's mental health getting worse? And actually, we could only compare the age group studied in the first survey, which was 5 to 15-year-olds, because 16-year-olds were in the adult survey, and the government didn't see the point of paying for them twice, sadly. But what you can see is there isn't the dramatic increase that many people thought we would find, but there is a slow and statistically, and I think clinically significant, deterioration in children's mental health. And that's almost entirely explained by the level of emotional disorder increasing. And in fact, the previously most common type of problem was severe impairing behavior problems, so oppositional defiant disorder or conduct disorder. Now, we could talk for an hour about whether they should be mental health condition labels, but the fact is the children who meet those criteria have absolutely appalling health, social and education outcomes. So whether or not we consider it a mental health condition in childhood, having that diagnosis predicted to every single adult mental health condition studied in the Dunedin cohort in the mid-20s, and that included psychosis and anxiety and depression, rather than which will be less of a surprise, as well as substance misuse and personality disorder, which will be less of a surprise. So whether or not the behavior problems are symptomatic of the environment or the child or the family or all of the above, the impacts of them are felt as adults as mental health conditions. So therefore, I think we need to try and treat these children. The increase in emotional disorders was seen in both genders. And I put this slide up for those who are perhaps less familiar with the distribution of mental health conditions within the child population that we'd expect to see. The percentages may be a bit higher, but we would expect to see this increase with age. And there are clear differences between boys and girls, which we expected to see. So boys predominate amongst the younger years. I think you can see my mouse. They're still predominating amongst primary school age. It's much more even in the early teenage years, with a flick to what we see in adults, which is a female preponderance of mental health conditions as a total in the older teenagers. Excuse me. And that's partly a reflection of the different types of problems that we see in those age groups. So amongst the younger children, the preschoolers, we see quite a lot of behavioural problems amongst the more temperamentally difficult children. And the less common disorders here will mostly be neurodevelopmental, so autism spectrum, and you will see there is a little bit of ADHD. You then start to get an increase in behaviour problems, but also emotional disorders in primary school ages. By early secondary school, emotional disorders are leading the field, as it were. And in these two age groups, the less common disorders are most likely to be tic disorders, which start sort of presenting at the upper end of primary school. And then when you get to the older teenagers, emotional disorders, particularly depression, which is rare before the teenage years, becomes much more common. And the less common disorders start being taken over by things like eating disorder and bipolar disorder at that age. When I meet people socially and I'm a child and adolescent psychiatrist, if they don't run away screaming, people often say, well, children don't need psychiatrists. Well, I think I've shown you that actually there are a lot of children who are really struggling with their mental health in our communities. The second thing they then say is, well, you know, and we had this at the press release, you know, how significant a problem is this? And as I say, what we were being asked to measure is, would this young person warrant specialist mental health intervention? So we had quite a high bar. And so I decided to study this. So we put the two earlier surveys together. All the children had a mental health condition in 1999 and 2004, and they were re-studied. The same sample was invited back 3 years later. Now, I put persistence in quotes because we don't really know what happened in between. All we know is that there were some children, roughly about the same proportion, about 10%, who met diagnostic criteria at either time point, but half of them are also met diagnostic criteria at baseline. These are not things that just go away. It's not just a phase. It's not just a little blip for a lot of these children. It's quite a long-term struggle. We also studied the predictors of persistence, and I think the reason I'm touching on this baseline epidemiology is I think if we're going to understand what research questions and what developments we need in practice, be that health, education, or social care, or the voluntary sector, then we do need to understand the basic epidemiology, or the basic risks and persistence factors for the conditions that we want to help. So what you will see here is that the disruptive disorders, the more externalizing problems, are more persistent than the emotional problems. That again is not a new finding. What we were able to do with this sample is study what predicted persistence, because it's not necessarily what predicts having the problems in the first place. And the things I want to pull out for you today are children's relationships are really important. So the children who were struggling tended to have peer relation problems. And whether, you know, this was peer relationship measured at baseline predicting to persistent problems 3 years later. The other issue is parental psychological distress, or the parents feeling that they're not able to cope with the child burden. So I think we need to keep an eye on parents, and those of us who work with children. If parents have their own mental health problems, we should be actively encouraging them into treatment separately to this work. And I'm not going to show it to you today, but I could come back and talk about it another time. We have studied the children whose parents have a mental health condition, anxiety or depression, and the children who have the same condition, but in both cases, the other party as well. And it predicts in both directions over three years. So in other words, a parent who's coping well, but who has a child at baseline who has anxiety or depression is much more likely to have anxiety and depression when we went back in 3 years' time, and vice versa. And I think, you know, for those of us who work with families, that won't be a surprise, but actually there's remarkably little in the literature about the impact of trying to parent a child with a serious mental health condition, and we perhaps need to take that more seriously than we do. So I suspect this is why Fiona invited me to come and speak to you today. I was one of the authors on this paper in Lancet Psychiatry, which you may or may not have heard of, which a group of us by the Academy of Medical Sciences and also a charity devoted to funding and promoting mental health research called MQ were really worried by the huge amount of money that was being diverted into studies around the physical aspects of COVID. Not because we didn't think it should happen, but what we could see was likely to happen was all the funding was going that way, and there was a real risk that people would turn around and say, well, you know, mental health isn't as important, so, you know, sorry. And yet we know that there's likely to be a profound recession after lockdown due to the lack of economic activity, and we know that that's disastrous for both adult and children's mental health. We also, at the time we were writing this, there were hints about the impact of COVID on the brain directly, and also via hypoxia, and we know more about that now. So this was a call to arms for researchers, but mainly aimed at the funders, saying, for goodness sake, there are going to be big mental health impacts, and we absolutely need to make sure that mental health gets adequate attention in the research response, which needs to happen. What we also called out to is the research community to make sure that they worked with people with lived experience, to make sure we ask the right questions and that they're the most important questions. And in fact, we had authors within that authorship group who that is why they were there. That research institutions and individuals should coordinate and collaborate. This has resulted in a plethora of registers. Everyone seems to want to have their own register of trials. And I'm aware of one university department where there are, well, one university where there are 3 studies on the mental health of children going on, and 2 of them are from the same department, which I think is a rather sad indictment, because that without the coordination and the collaboration, we risk leaving some questions unaddressed and we risk duplication. And it just, you know, if you think of the amazing work that oncologists have done, where they're all built into trials, virtually every patient they work with goes into a pragmatic trial, and it's hugely collaborative, and it's responsible for the dramatic changes we've seen in survival from cancer. And we just in mental health need to do better. We argued for a global perspective and that the research should be multidisciplinary, and that's reflected again in the authorships. But we also had a plea to maintain high standards, and I'll come back to that in a bit. And then we pulled out some really key areas, which I think we need to understand who's suffering from mental health conditions and what influences that. We do need to make sure that the more basic science isn't pushed out, because the social problems are important and perhaps more obvious. There are certain groups who are seem particularly vulnerable, and children are named because I think they are particularly vulnerable. They will pay for this pandemic, literally, and the amount of education that they've lost and the risks to which they've been exposed at home, some of them, not all of them, I think will impact them adversely. And in fact, the follow-ups from previous epidemics and the 1918 flu pandemic demonstrated that actually many children never caught up. They didn't do very well educationally, they didn't do very well occupationally. And in more recent epidemics like SARS and MERS, those who were quarantined quite often had post-traumatic symptoms, particularly if they'd had to go somewhere else without family, or particularly if they'd witnessed relatives who were very unwell on ITU or had been bereaved. So we need to think about all of that. We also need to think about how we scale up our interventions, because there are going to be many more children who need them. So coming back to the issue about study quality, for those of you who are interested in research, I really recommend this website, and I've put the link to it on the slides, and I can give you a PDF of the slides taking out the unpublished information after the talk if you would like that. But this is a group who are doing the most heroic living systematic review. And what I mean by a living systematic review is that they're working on this daily and it doesn't ever finish. They have 3 interlinked systematic reviews, and if you go onto the website you can see precisely the criteria they're using. It's very carefully defined. So review 1 is about changes in mental health. So they're wanting reasonable quality surveys or cohorts that are well characterized, that have data before COVID, so they can actually talk about changes in mental health because they've measured them. Then they've got slightly looser criteria for looking at associations. So these are some of the convenience surveys are going in there, but they have got some quality assurance factors, which you'll see are having quite a dramatic effect. And then the last thing is they're looking at interventions that are related to particularly mental health deterioration related to COVID. I checked the website yesterday. At that point, they had screened over 14,000 abstracts, in addition to nearly 260 registered trials. And yet look how many studies they thought were good enough to include in the review. The signal to noise is just appalling. And this is why they have done this, because what on earth is somebody who hasn't got hours to read papers, you know, someone busy in policy or busy in practice. And, you know, this relates back to we really do need high quality research, because rubbish in means rubbish output. And that's no help to anybody. We enlarged, a group of us who are epidemiologists, and again, this is really for the people interested in research, in another brief editorial in the Lancet Psychiatry, because of the fact that those of us who were trying to get high quality surveys off the ground, which of course, if you've got to go back to people who are the data controller for existing data, it takes longer than writing a few questions and shoving them out online. And that, you know, when you need data quickly, actually there is an argument for doing something quick and dirty just to kind of get a sense of what's going on. But there is a real sense that if it's really big, then it must be good. And that's just not the case. A biased sample is a biased sample, however big it is. So for example, I won't name the journal, but there was a Chinese study. So China has fewer women than men, and it had 65% women in it, and they were trying to argue that it was representative of the population. Well, it can't be. It doesn't matter if it's 52,000 people, it's still biased. And the reason for this is that if you carefully select a sample, then you can use statistics to estimate how precise your sample is. But if you don't know who you've got and who you haven't got, then you can't do that. The theory doesn't support the statistics. It doesn't mean that people don't do it, but it's incorrect. And cutting corners can result in poorer evidence for policymakers, and does. So what do we know so far? Well, the first systematic review, and again, I checked this last night, so unless they put something on this morning, there is only one study I can find on children that's got some baseline data before lockdown. And that's not on their database yet. I just happen to know because it's being produced by a colleague. You will see in the resources I've put in the slides, which you can have afterwards, the Royal College of Child Health and Pediatrics has a really useful summary of studies that relate to children that have been completed, that they're aware of, that are in the field and that are planned, and links to results where they're out. And I would keep an eye on that. But in terms of the adults, well, we might be able to extrapolate. 4 of the 9 studies are on students, and some of those who, you know, work with children, work with young people into their early 20s. These seem to suggest that depression has increased more than anxiety, but both types of symptoms have increased in most of these surveys. Now, some of them were quite small. 178 may sound large to those of you who aren't used to epidemiology, but if you think, if you're taking a whole population, a general population, and your prevalence is about 12%, that means for any kind of mental health problem, 12 in 100 children will meet diagnostic criteria. So a sample of less than 200 is only going to give you 24 with any kind of problem. And then when you're dividing that up into smaller groups, perhaps by age or gender and type of condition, you're down to tiny, tiny numbers. And one child being misclassified, which will inevitably happen, will really skew your results. There have been 3 population studies, 2 of them from the UK, 1 from Canada. That doesn't quite add up. I know where that's come from. The one in Canada, Ireland and Brazil is this one, which is of people with a very rare disorder called systemic sclerosis. And it's interesting that this group were very anxious but not depressed. And I think what this is getting at, if you think of students, they're highly social, their university career or college career is quite short, so actually missing 6 months of it is a big hit, and that may well disrupt all their social relationships. So I'm not surprised that that group perhaps are getting more depressed than anxious, and in a way that's appropriate. They're much less at risk than, say, this group with systematic sclerosis, who, if they got sick, would be likely to get very sick. And maybe if the health service was overwhelmed because of their chronic condition, would be less likely to get active intervention than others. Likewise, in a sample of people from the lesbian, bisexual, gay and transgender population in the USA, again, anxiety prominent. What we're not seeing reports of, and maybe because the experience of lockdown and college closure and work closure is universal, is traumatic symptoms and the sense of stigma that comes from being quarantined when not everybody else is. And I just wanted to highlight the size of the study there, which I've done already. So coming to the one study, which is available as a preprint on children, and these children were sort of 8 to 9 before lockdown, about 18 months ago, and then were assessed when their mean or average age was just over 10. This was a study that was monitoring children in school, looking at their cognitive function, but they had some mental health measures in it, so it's advantageous. This was a group that were being studied for another reason, but the idea was to get a general population sample. You will notice it's quite small. It's not a fabulous response rate. It's about, what, a third? It's reasonably evenly split for gender. Only 8% were eligible for free school meals. The average for England at the moment is about 18%. So that is an affluent sample. They looked at the emotional subscale of the SDQ, and they had the RCADs, the short 25-item RCADs, to measure anxiety and depression symptoms. And what they found, and I think this is really significant because depression symptoms are so rare in this group, they found a significant increase in depression. Well, as I said, when you need data and you haven't got anything else, quick and dirty is not bad. So there are two other studies that I'd like to highlight for you. Young Minds has done a survey of people with lived experience of mental health conditions. Some will be service users, but not all of them. So they had about 2,000 responses. The young people were in their teens and early 20s. And it was very early days. So I think the lockdown in the UK was the 23rd of March. So this is very early on. A third felt their mental health was worse, was much worse, whereas 51% had said it was already deteriorating. And there are this interesting group who I'm fascinated by, who said their mental health was a bit better. And I think this is something anecdotally we're hearing quite a lot of. So I'm plugged in because of research work I do with two organisations that support parents whose children struggle to attend school. One is called Not Fine in School and the other one's called Square Peg. And they, prior to lockdown, were getting about 600 inquiries a day by parents who were, some of them being threatened with being fined, but, you know, really quite severe problems and not knowing where to turn. And then if you look at their metrics after the end of March, no, just a sudden off a precipice. And suddenly the comments on their Facebook pages are all, I cannot believe how changed my child is. And I think we have to really think what our education system is doing and how it's set up. If there's a sizable proportion of our population who are actually doing better when the schools are closed. We now have secured funding to go back and study that 2017 survey group. The first questionnaire is in the field as we speak, and we're going back to everybody who said we could, which is just over 7,000 people. What kind of a response rate we'll get after 3 years and given the current condition, I don't know. But we're hopeful of getting about 5,000 responses, which will be a decent sample. It's a carefully selected sample. And what's more, we know an awful lot about everybody. So even the people who don't come back, we will know how they were doing before. And we are asking a question about, you know, is your life better in any way? And we will sample the group who say yes and talk to them about what's changed. There is another, again, aimed at teenagers and emerging adults. I think the WHO term is now called UCOPE, and it's being run by UCL and Imperial. This has reported already. It reported in June, so again, it's early on in lockdown. It was a convenience survey. It went out over social media, so we don't know the sample frame. We don't know who didn't respond, but a third reported decreased income. Over 3/4 had a dramatic change to their education or employment, and that's even higher amongst teenagers. 24% had to change their living situation, and more worryingly is the figures for the people losing out on their health care, particularly mental health care. This sample seemed to do a better job of reaching those of lower socioeconomic status, but it was mainly younger teenagers and more women, more young women than young men. So the data needs to be offered up with that in mind. There is another study run out of Oxford, which is similar, but it's going to parents and younger people. Again, it's a convenience sample. It's going out over social media, and it is, despite the investigators trying very hard to engage with people of Black and ethnic minority and people in lower socioeconomic status, it is being responded to mainly by those of more affluent backgrounds and those who are primarily white. So the first update was really, I think, about generating interest. At this point, they only had just slightly under 2,000 parents responding. And they were saying that they were finding it really hard. This was at the end of April, I think. 3/4 said they were really unable to balance their work and parenting, and the main family tensions were around their children's well-being, screen time, as well as work-life balance. I think any of us who have been trying to combine full-time jobs with homeschooling children will sympathise with that. The second update was on when they had their first 5,000 responses, so bigger at this point. Children reported, and they had responses from children from the age of 11 up. Children were worrying about their friends or family catching COVID. They were worried about missing school. And again, high numbers reporting disruption to services. And parents of children with special educational needs and disability were reporting hugely increased stress levels, that their children were really struggling with the change from lockdown and homeschooling, and that their behaviour was becoming increasingly difficult to manage. The third update was more recently, and they were asking slightly different questions. Now, we don't know, the responses at each time are anonymous, so we don't know if these are the same people reporting. But half of the parents who reported were really uncomfortable with the idea of their child returning to school, particularly if the child had special educational needs and disability, mainly related to concerns that there wouldn't be enough support. But also parents who don't work outside the home and those of lower socioeconomic status. The children were more worried that school would be different and that all the fun things would be stripped out. The final update was a more detailed look at the first month in lockdown. And this is really interesting. So parents reported that amongst children, and by that I roughly mean primary school age children, on all subscales of the SDQ, the children were scoring worse. So on average, our children's mental health has deteriorated across the board. So emotions, behaviour, and restlessness, inattention. Young people reported decreased emotional difficulties, but that they were increasingly restless and unable to concentrate. If the child had, about young people, this is parents reporting, so decreased emotional difficulties and increased restlessness, unless the child had a special educational need or mental health condition pre-existing COVID in both groups of children, so across the age span for children, again, decreased emotional difficulties. This is not saying very positive things about the support we give our children in school, I think. But young people themselves reported no change. So where does that leave us as we think about schools opening more fully in September? I think we need to be really worried about those with pre-existing mental health conditions, particularly those on the autism spectrum, for whom change is always difficult to handle, because the child may have found it easier to be at home and to access education at home, or maybe not. And they may really struggle to get back to school, particularly for those on the autism spectrum, for whom they won't be going back to the same school and they'll find the difference really hard to manage. But I suspect we will see a spike in children struggling to attend, because for those for whom school is a stress, going back after weekends, half terms or holidays is difficult. When you've had 6 months out of the situation, I think that's just going to make it all the harder. And those of us who work with children with anxiety and depression need to think about how we're going to support schools to support these children and families, because it's not something that many areas do well. There will be children who've had very adverse experiences. So I think somebody beautifully said, we might all be in the same storm, but we're not in the same boat. And what COVID has done is open up inequalities. It's one thing to access 4 or 5 hours of online teaching via a laptop in your bedroom. It's another thing when you have a family of 6 in a 3-bedroom flat and you have 1 laptop between all of you and perhaps not reliable internet, and you don't have a garden, etc. You know, which family is going to have the more tension, the more arguments? We've seen a dramatic rise in calls to domestic violence lines, which was predicted. There are worries about the sales of alcohol. So we've got children who may be getting involved in substance misuse, but they may well be witnessing domestic violence, involved in domestic violence. If they're not having access to lessons, they may well be getting involved in gambling, cyberbullying. We've got a lot of people who are exposed, have more opportunity to get exposed or be exploited, and less monitoring. Children don't often refer themselves, and certainly in England, the uptake of vulnerable children going to school has been tiny. So there's a whole range of children who schools were already worried about, for whom there is no legislative structure around them getting social services involved, and social services isn't keen to do home visits unless it's an emergency. So we have less idea of what's going on, but we're fairly clear that there are almost certainly more children in need. We need to get people back into school so that there is a support structure and that it defuses the family situation where it's not good. And we can expect that with the recession and job losses, debt is very toxic to mental health, and parental mental health impacts on children. So there are going to be lots of families that are struggling. Research priorities, well, I think I've highlighted a lot of them, but I do think actually services have had to really respond to the changes that they've seen. And we've done so very well. So, you know, I have colleagues at South London and Maudsley who are busily putting all their group treatments online and carrying on with them. That's not the same everywhere, and not everybody will want their therapy coming into their home. For some, the home isn't safe enough, but we've seen some dramatic changes from which there are benefits for some people. What we need to do is to understand for whom it is a better option and when it's inappropriate, and we need to co-produce with people with lived experience and guidelines around the etiquette and the boundaries and risk monitoring and safeguarding. We are going to be dealing with many more children who have vulnerabilities, and poor mental health will be one of those vulnerabilities, and that is likely to persist for some years. Now, we had services that were struggling to cope before COVID hit. We need to think about how we scale up interventions and we offer them in a step manner. It's no, you know, for me, it's the greatest good for the greatest number. Giving a tiny proportion of those who need it a Rolls-Royce service and the others nothing doesn't really seem the best option. So just to finish up, we have the general population of children, most of whom, I'd like to say most of whom, it may be only just most, but most of whom will adapt and adjust. You know, one thing that human beings are is amazingly adaptable. And there will be this group at the top who, for a complex reason of their social situation, their genetic makeup, their medical history, their family situation, would never cope in a mainstream school or would have a mental health condition. And then in between, we have a vulnerable group. And I think what we're going to see is this vulnerable group is going to get bigger. And so we need to think of universal, targeted and indicated strategies to try and help them and to reduce the vulnerable group. I'll stop there and take questions. Thank you for your attention.
Thank you very much, Tamsin. I missed a little bit at the beginning because I was busily trying to find a computer that worked. So I hope I don't log out. Tamsin, I'm just interested in some of the data that you showed, some increase in maybe anxiety more than depression, maybe in younger more than the older kids. and the difference between parental report and the young person report. So again, the parents are seeing it more than the young people themselves. And all of that is done presumably on just one stage screening. And the risk of, with COVID and maybe some of the methodological difficulties that make your more typical two-stage, epidemiological studies more difficult. Could you say something about, whether we're looking at transient increase in distress, which would be normal, whether it's a proxy for parental stress rather than, because it's parentally perceived rather than, reported by the young person, and the risks of, spending too much time dedicating services or funding or research without being sure what you're seeing?
That's a very good question. I think we need to do high quality research to find out what the problems are. I think there are hints from the better quality studies in adults that, so I didn't go into it in depth, but one of the adult surveys is on the UK longitudinal health survey. And so they have data from 5 or 6 waves prior to COVID on the same people, starting at age 16. So there were some 16-year-olds in 2015, and they've gone back and got data. So we don't have younger children, but we have got older teenagers going right up to middle age, and we've got several waves using the same methods. Now, what those showed was a deteriorating trajectory that in everybody, and these data were collected in May, I think. In May, and the paper submitted in June. So people have worked very hard to turn this around very quickly. Now that the trajectory of increase went up, but it went up most consistently amongst women, amongst young people. This was 18 to 24, and amongst those of lower socioeconomic status. And because the data was collected in May rather than in February, March, when it all first started, that suggests to me it's not transient. But, that's the first really good methodological study that we've got in adults. It was followed by another one from the Ausbach, and also a Scottish survey, and I can't remember the name of it. Now, the Scottish people are in their late middle age, in their mid-50s, and the Ausbach sample, of course, are approaching 30. So not very relevant to children, but a similar thing, levels of anxiety that were raised. But again, this is quite early on. So it will be very interesting to see what the National Survey in Children says, because we're collecting the data now in July. And if it was a transient response, you would have expected the symptoms to have increased and subsided again by now.
And also you'll have a before and an after COVID, which would be, very helpful. Is there any evidence from clinics in the UK that we're actually seeing an increased referral rate of children? I know you have to balance it with reluctance of people to refer and attend, but is it being shown as well that the distress is reaching a certain level that somebody is wanting to refer them?
I think what we're seeing across the board, actually, so all areas of the lifespan, certainly in Cambridgeshire and the Cambridge and Peterborough Foundation Trust, somebody's looked at all the data for mental health services, and also they do ambulatory care for physical health. Across the board, there is a dramatic decrease in referrals based on the same period last year. And it's not matched by increased attendance at accident and emergency or increased telephones to the crisis line. So there is a reduction in presentation, but that's been seen in other conditions. So for example, the British Paediatric Surveillance Unit did a just one-off, have you seen children presenting very late or too late, and got something like 40 or 50 deaths reported of young children where they had meningitis or something really serious and they didn't get to healthcare in time. So I think whether it's a fear of going into the hospital environment or a wish not to burden things or just thinking the services aren't there, we have seen both a reduction in the amount of service we can offer, but also a reduction in demand. That to me, I think, is a reflection of the fact that people aren't seeing the children. Children are notably absent, certainly in the UK, from policy and from the news about, you know, our response. You know, the fact the pubs are open before the schools are, I think, just says it all about how we're responding to this crisis. So I don't think the level of service use says anything concrete about the level of mental health in the population. I think it's about barriers to access at the moment, whether they're perceived or real.
I mean, I guess what I feel is that it's so important to have methodologically robust studies out there so that you can have real validity. Even the fact that the study that you mentioned that showed an increase in mental health presentation that superseded emergency department referrals. I mean, Dr. Barrett's work from before COVID would even have found that more recently the increased surge of mental health presentations to the EDs was far greater than the increase in general pediatrics. So it's something about making sure that if we are talking about the stress of COVID, which affects, you know, so many different people, to make sure that we're giving the right message out there to the public, and that those among us involved in research are actually distinguishing between mental distress, which it may be transient but still impairing, as opposed to, you know, a group of real increase in mental health psychopathology.
I agree totally. So, you know, what we haven't managed to do is persuade the government to go back and do a full resurvey. It is only going to be questionnaires. There will be mental health measures and other measures that reflect what was collected in 2017. But what we're also going to do is get a bit more detailed information with some semi-structured interviews around key things like access to services, access to education, key stressors, at the same time. Now, obviously, we can't do that on 6,000 people, but we can sample groups to do that in a bit more detail.
Talking a little bit about the methodological issues of research at the time of COVID, I mean, notwithstanding the quick and dirty benefits of doing the surveys, I guess the qualitative research to me would be something that would really give a lot of insight into the nuances and the variations of the stressors. Even the idea that for some people, the 16% there was no change or a reduction in stress, you know, following that through with qualitative interviews would allow you begin to unpick some of that. Are you planning that in your...
Yeah, absolutely. So that's what these semi-structured interviews would be about. So, for example, for the service use question, we would hope to interview all those who say they've had a mental health related service contact, and then a sample of those who haven't but who are service relevant. In other words, they highlight that their child has a problem, preferably at baseline and at follow-up, and certainly in previous surveys when we've done this, we had enough to do that. And then to have a conversation with them, a semi-structured interview about their experience of services and their concerns. And certainly, yes, one of the groups I want to talk to are the ones who say that life got better during lockdown, because I'd like to know why. You know, because I think it will have some things to say about the way institutions, particularly schools, but maybe also services, are organised, that when they're not available, people are doing better. It's really just not how it should be.
Yes, yes. I had a thought in my head. I was sending a text there to somebody asking if anybody else would like, the thought is gone. Would any of the audience like to raise their hand and unmute themselves and make a comment? We're nearing the end of our presentation. Elizabeth, would you like to make a comment?
Hi folks, I'm so sorry, I was struggling to unmute myself. I'm just totally really blown away by what Tamsin has managed to do, and I feel really jealous, Tamsin, of all of this data that you're collecting, and I wish we could do it here, you know. And I suppose one of the things that's been so fantastic is the service user engagement and the way you've managed to sort of propel that into conversation with policymakers. And I think maybe in Ireland that's a real challenge for us, that sort of interface between practice on the ground and policy. I just wonder, have you any, you know, so I certainly feel a little bit hopeless about that here at the moment. So any thoughts that might inspire us a little bit in terms of flying that flag?
I just keep trying to fly it, and eventually people will listen. Really, is the only thing I can say. And I think it's demonstrating to people that actually your research is better. You ask the right questions, you collect the data in the way that fits, you know, with people who have the experience that you're trying to measure, so you get a better response rate and better quality data. And you know, they will also help you disseminate it out to the audience. So I think if you do it and keep telling people how good it is and what a difference it makes, you will find that people slowly come around. It's a long game, but don't lose hope. Keep plugging away. And you know, recently I was sitting in a committee where some very surprising people were actually, for the first time ever, not kind of dismissing PPI as something that's, you know, soft and fuzzy. And, you know, I'll say I'll do a qualitative interview in that box, which, you know, is research, it's not PPI. But, you know, people are really beginning to take it seriously. I think what swung it in England was NIHR, because they have a huge emphasis on it in their applications. And once funders demand it, then people have to do it. And then when they start doing it, they realize that actually there's a reason for this. It works, it helps.
Mm. Thank you, Liz, for your comment and question. And Tamsin, I want to just be mindful of the time of our audience in terms of they probably have to move on to other activities. It would be lovely to talk to you more about both methodological issues, but even our maybe we need to bring to current studies that have started before COVID and have had to change, and you know how we're thinking about doing that so that they will be valid at the time of reporting, and you know, to read studies that come out with extra caution so that we're not inadvertently you know, following wrong leads. But thank you very much for that. Just we need to finish, and I'd like to kind of mention that the next talk that we're doing next week is by Stephen Taylor, and it is the psychology of pandemics and preparing ourselves for the next pandemic. Very sadly, we are anticipating a second surge. Tamsin said schools haven't been opened, but pubs have. And although there's a little bit of reticence on the Irish side now that maybe we should pull back and not open our pubs as soon as we thought, you can definitely worry about ongoing surges, particularly with holidays coming up, some by the young people, some by older people going abroad, and what's that going to happen. So I think next week's talk will be very interesting. I'd like to, as always, thank all of you for giving up your time to listen to us today. I apologize. I was certainly distracted and unprepared for being locked out of it at the beginning. I didn't mention that I'm delighted to my colleague Bloned Gavin for continuing to co-host with me, and Paul Harkin, and also the College of Psychiatry of Ireland. So thank you very much, everybody. Have a good Friday and a good weekend, and hopefully we'll see you again next week. All the best. Bye-bye now.
Bye, thank you. Nice to see you all.